this is one topic that I was very passionate about and wanted to make sure that it got included. Ms. Latin is a licensed professional counselor specializing in perinatal mental health. In 2013, she earned her master's degree in counseling and guidance and a graduate certificate in dynamics of domestic and family violence from Louisiana Tech University. She is licensed in 3 states, Louisiana, Georgia, and Texas, and is the owner of JL Counseling and Mental Health Private Practice located in Shreveport, Louisiana. Jessica is a nationally certified counselor and holds an international certification in perinatal mental health. Jessica has additional expertise in domestic violence and self-esteem building. She provides clinical supervision for those seeking licensure in Louisiana and was recently appointed as gratis clinical instructor of psychiatry and behavioral health at Louisiana State University Health Shreveport. She has recently completed training to become a doula to help provide additional support to pregnant and postpartum women. And I'm going to let her go ahead and get started. I'll stop sharing so you can share.
Thank you. Hello, everybody. Good afternoon. All right. Can everybody see that?
Okay. Yes.
Okay. All right. Thank you, everybody, for tuning in. I'm very excited to talk about this particular subject on maternal morbidity and mortality, but specifically, today we'll be exploring the physical and mental health effects of substance use during the perinatal period. And again, I'm Jessica Latin, and I'm a licensed professional counselor and perinatal mental health certified. She already shared a little bit about me. Aside from the things that she shared, I am also a volunteer and an advocate for maternal mental health. If those of you who aren't familiar with Postpartum Support International, it's a wonderful organization that talks about perinatal mood and anxiety disorders, as well as perinatal substance abuse. And if you want more information about that organization and how you could become certified as well, because they have a therapy track as well as a psychiatry track, I highly recommend that you look into that at postpartum.net. And I have no financial disclosures. Okay, so today we will be talking about a few things. So number one, we will be listing the various health outcomes and risks associated with substance and alcohol use in pregnant women. We will be discussing the maternal mortality trends associated with substance use during the perinatal period within the US and in Louisiana. And lastly, we will review substance use treatment options currently available, and we'll discuss some of those barriers to treatment for pregnant and postpartum moms, postpartum patients, in hopes that maybe we can do some more advocacy work to get better treatment options. All right, so substance use, Okay, substance use risks in the perinatal period. All right, so these are risks associated with alcohol use during the perinatal period. So we have miscarriage, stillbirth, infant mortality, and congenital defects, low birth weight, reduced gestational age, preterm labor, fetal alcohol syndrome, adverse neurodevelopment outcomes, cognitive and behavioral challenges, speech and language delays, executive functioning deficits, and psychosocial consequences in adulthood. Now, smoking tobacco. Some of the risks include umbilical cord damage, miscarriage, increased risk for ectopic pregnancy, low birth weight, placental abruption, preterm labor, infant mortality, higher rates of respiratory infections, SIDS, behavioral dysfunction, cognitive impairment. and limited time breastfeeding. So with that, a lot of moms, if they were previously smokers, they probably won't breastfeed for the recommended amount of time. And so that time will be limited. And of course, that will have effects on the outcome of your baby's health, if you quit breastfeeding too early to go back to smoking. All right, risks associated with marijuana use. No, that's a big topic, especially with the political things, legalizing marijuana. So some of those risks include preterm labor again, low birth weight, small for gestational age, admission into the NICU, adverse growth of the fetal and adolescent brain, reduced attention and executive functioning skills, poor academic achievement, behavioral problems. Okay, next we have cocaine use. And some of those risks include premature rupture of membranes, placental abruption, preterm birth again, low birth weight. It's pretty much a common theme throughout all of these. Small for gestational age. Methamphetamine use risks include shorter gestational age, low birth weight, fetal loss, developmental and behavior defects, preeclampsia, gestational hypertension, intrauterine fetal death, and opioid use, which is one of the biggest ones, include low birth weight, respiratory problems, third trimester bleeding, toxemia, mortality, neonatal abstinence syndrome, postnatal growth deficiency, microcephaly, neurobehavioral problems, and SIDS. So neonatal abstinence syndrome, for those who aren't aware of what that is, it's basically withdrawal symptoms it's the conditions that come from withdrawal symptoms of being exposed to certain substances in the womb. It's most often caused by opioid usage, and it can last for about 1 week to up to a few months, and there's no sure way of telling how long it will last. It just kind of varies from baby to baby. So some of those symptoms include irritability, feeding difficulties, tremors, hypertonia, emesis, loose stools, seizures, respiratory distress. All right, and other risks that are associated with perinatal substance use that some people may not think about include disruptive household environments, at a higher risk of being exposed to dysfunctional parenting styles, neglect, poverty, domestic violence and abuse, and a high risk of arrest for the mother, because a lot of times that is considered to be child abuse in many states. Child removal, comorbid psychiatric illness, lack of prenatal care, poor nutrition, and chronic medical problems, as well as early dysfunctional maternal-infant relationships. So it will definitely affect the bonding. All right, substance use in the perinatal period. So co-occurring substance disorders are common with pregnant women with substance use disorder. It's highest in those who use alcohol, cocaine, amphetamines, and opioids. Cannabis and tobacco use disorders are typically diagnosed together and are one of the most common additional substances used in conjunction with alcohol, cocaine, opioids, those types of things. Of course, during COVID, there was an increase in everything. And the Journal of Reproductive and Infant Psychology reported an increase in psychological distress, which led to an increase of substance use in pregnant women. And so the most common substances that were used during this time were cannabis, alcohol, prescription pills, not prescribed to the individual, smoking, and vaping. All right, so let's look at some maternal morbidity mortality rates. Okay, so the national inpatient sample, this basically just shows the opioid use disorder increase over the last 20 years, basically, out of every 1,000 delivery hospitalizations. So from 1999 to 2014, we saw a major increase across the entire country for opioid use. And here's some more detailed descriptions of the different states in the United States. As you can see, some of these states are not on here. And the reason for that is because they were not a part of this healthcare cost and utilization project. And of course, I think Louisiana was not on here at all. But I do have some stats on that. But as you can see, there's significant increase. It was pretty low in 1999 on the national level, but then just slowly started to increase as time went on. For the states that we don't have any data for 1999 to early 2000s, but you can see even when they started to come on kind of in the mid 2000s, it was a significant growth over time. Okay, so Louisiana stats, and we've just heard from a previous presenter, some of these stats may look familiar to you. So the Louisiana Pregnancy Mortality Review Committee has a great report out about the statistics on maternal mortality over the last couple of years. So accidental overdose specifically, they had 2 pregnancy-related and 27 pregnancy-associated deaths from 2017 to 2019. And if you look at the different regions, New Orleans is one of the highest areas, Region 1, where I'm located in Shreveport. We have 17. And Lake Charles and Alexandria are one of the lower ones. And these are pregnancy-associated deaths from 2017 to 2019. All right, some more stats. So overdose and motor vehicle crashes were the leading causes of these pregnancy-associated deaths, and substance use disorder probably contributed to more than 1 in 3 of these pregnancy-associated but not related deaths. From 2017 to 2019, there was an increase in accidental overdose and suicide in pregnancy-associated deaths, totaling about 40 cases. And in 2019, there were 2 pregnancy-related accidental overdose and 5 pregnancy unrelated suicides. Social history included a high history of substance use, a history of treatment of substance use for these particular deaths, history of psychiatric hospitalizations, history of previous suicide attempts, and they've had a history of childhood and other traumas. So there's definitely a connection there between trauma and mental health and substance use. All right, and we heard this before, but this is something that is very, very important and definitely reflects the disparities. in not just our country, but in our state. Black women are 2 to 3 times more likely to die in Louisiana from pregnancy-related or pregnancy-associated unrelated deaths. So that is definitely something to look at and try to work on to help minimize that. And that's been like that for many years. And in this review, they discovered that 80% to 88% of these deaths were preventable, whether they were pregnancy related or not. And that's a huge problem. So we definitely have to figure out how we can improve treatment and improve just how we are working with pregnant and postpartum women to help prevent these deaths. Okay, so options and barriers to treatment. So some recommended treatment for opioid use or substance use in general. So methadone has been used since the 1970s. It's recognized as the standard of care since 1998. The cost of it is approximately $126 per week, and that includes daily visits, including integrated psychosocial and medical support. And then buprenorphine, I cannot pronounce this, sorry, is a 10% lower cases of neonatal abstinence syndrome. Less morphine is used, and it has a shorter neonatal treatment time when using this. Higher gestational weight and age and head circumference at birth is also an incentive for that. The cost is approximately $115 per week, and that includes medicine and twice weekly visits. So it is pretty expensive. So you have to look at people that are in poverty as well, if they would even be able to afford treatment like this, which many cannot, and they go untreated, and it just continues the cycle. So definitely need to work on having a more cost-efficient treatment for all. So some behavioral interventions that are recommended include a contingency management with financial incentives. I've seen that done even with paying. I know Louisiana has done this in the past where they'll pay parents to make sure that they're taking their child to their baby visits. So this is definitely something that might be good for substance use treatment, is giving these financial incentives, whether it be gift in the form of gift cards or whatever. Motivational interviewing is another good one. Just taking a step back and trying to help that individual figure out what is most important to them and not necessarily what everybody else deems as important, because that will definitely make a huge difference on their success overall with their treatment. And then cognitive behavioral therapy, helping them to explore their triggers and their thoughts and feelings that cause them to use. So barriers to treatment, there's a lot of barriers, and these are just a few. So hopefully looking at these can spark some thought in your mind, and hopefully you will advocate for some of your patients and people that you encounter to improve their access to treatment. So, of course, criminalization of substance abuse, particularly as it relates to like marijuana usage, but just in general, a lot of moms who are using substances, they do not go to the doctor, they don't seek help because they're afraid of getting arrested. They're also afraid of CPS involvement. I am a former foster care worker. I have had several newborn babies as well as small children that have been removed due to substance abuse exposure. And that just creates an even worse cycle of problems. Avoidance of prenatal care due to fear of detection, like I said before. And treatment facilities only offering non-medicated detox. So a lot of these pregnant mothers who are using, they want to get the treatment, but they don't want to do it without medication. But it is a liability to these treatment facilities if they give this mother medication and something happens to her or her baby. So a lot of times they won't offer a medicated detox, and that could be pretty painful. Returning to the same environment post-detox is a huge barrier to treatment. If you're going back around the same family members or same friends or hanging out in the same spots, or being triggered by things that trigger your emotions that cause you to use, then that is definitely going to lower your success rate. No proper aftercare procedures to prevent relapse. So many patients are unable to, or they choose not to go to follow-up appointments, or it may be a long wait time until they're able to get a follow-up appointment, and that can prevent them from being as successful as possible. Hospital refusal to supervise withdrawal due to risk of miscarriage. Again, it can be a liability, and some clinics and hospitals just are not willing to take that risk. Childcare during treatment is a huge problem. So if you have more than one child and you have to go into a rehabilitation center and they don't allow children over the age of 5 or over the age of 10, that can create a problem. Or if they don't allow children at all, that could create a problem for someone who has a limited support system. So childcare is definitely something that is needed. I remember interning at CADA here in Bossier is a treatment facility, and they actually had one of their facilities was for mothers, and they could bring their children with them. But I think the age limit was they weren't allowed to bring children over the age of, I believe maybe it was 9 or 10 years old, because it is a risk. But I did like the fact that they could, if they just gave birth to their baby, they didn't have to be separated from their baby. And so that prevents CPS from having to be involved or having to, give your child to other family that might not be as supportive. Lack of support. Again, many people have burned bridges with their substance use and have just created a lot of problems for themselves with their substance use. And so their support system is very low. Lengthy waiting periods before admission. So there are a lot of, wait lists and things like that to get into a lot of these treatment facilities, as well as transportation issues as well. All right, so here are just some recommendations for improving outcomes. So we need to have more frequent screening, more educational programs and awareness programming for patients as well as providers. There needs to be a universal screening, and just ensuring that we are screening everyone and not just the people that we assume to be on drugs based on how they look or how they behave. Because I remember, just working in child protection, how there were people that you would never think in a million years that they were on drugs. And I'm pretty sure the doctors had no idea until the baby was born and was having problems. And then that baby had to be removed. So frequent screening, regardless of, and like checking our biases as well, just to ensure that we are giving quality care. More residential treatment facilities that support pregnant women and allow for them to bring their children if they want to bring them. Some people do have adequate support, others do not. It should at least be an option. And we need more residential treatment facilities, especially in Louisiana or other states that have a lot of rural areas. It can be hard for people to get all the way to the next big city in order to get treatment. So there definitely needs to be more, maybe smaller facilities that can provide easier access. Increased funding for methadone clinics and increase grant funding overall for hospitals, clinics, and other educational programs in order to help serve this population. Better communication between providers and patients. Most of my clientele are pregnant and postpartum parents, and one of the biggest stressors for them is not feeling heard by their provider, feeling ignored, feeling like they don't know their bodies, or minimizing their feelings or their desires. So having that communication, that good, strong communication between you and your provider can make a huge difference. It can build that rapport and that trust that's needed for them to be able to say, hey, I'm struggling with substance use and I need help. So just improving your communication overall will definitely improve outcomes. Increase training for providers and CPS workers to help us to develop just another option, maybe instead of removing children from the home, helping to put services in place so that they can still have that bond and still try to rebuild their family without the headache of having to go through the foster care system. Wraparound services is kind of what I was thinking. Wraparound services is usually just a number of different services. So it could be a doula, it could be your OBGYN, it could be a nurse that comes in for better continuity of care and follow-up. And that is it for me. I think I kind of moved kind of fast, but does anybody have any questions?
We're seeing lots of clapping and hearts for you. Does anyone have any questions?
We have got one. What resources are available for Medicaid patients?
That's a good question. So the SAMHSA.gov, I would say, is the one that I would go to. Most of these facilities do take Medicaid because they have federal funding. So I would go to SAMHSA.gov. It's SAHMSA.gov. I think that's what it is. But it's SAMHSA.gov.
Okay, and then our next question is, do you think this population can be served effectively via telehealth?
I do. I mean, at this point, I think we have to kind of get used to telehealth as part of the normal now. It is definitely more convenient. From the mothers that I serve, it's definitely more convenient for childcare purposes. You can actually kind of get a bird's eye view of what's going on in their home because you can see their surroundings and everything. So I think telehealth can be effective, just depending on the client. So if you have a client that may have some comorbid mental illness that may be struggling with psychosis and things like that, they might not necessarily be appropriate. So that would just be based on just kind of judging based on the individual and what their situation is. But I definitely think that it can be effective.
Okay, we got some other questions pouring in. Are women prosecuted in Louisiana for SU while pregnant? And if so, are there any leads in working to resolve it?
You know what, when I was working in child protection, I don't recall them being prosecuted. All I recall is just the removal and them having to work through a plan to get their children back. So in Louisiana, I don't think that they are prosecuted. And I remember when I was doing my research, it was one particular state. It may have been Alabama. Don't quote me, but it was some of the southern states do have that law where mothers are prosecuted. And what was the other part of that question?
The other part of the question was, let me get to it. basically, if there are any cases like that, are there any leads in working to resolve that issue?
Right. And no, I haven't heard of anything. I don't think that's a big issue here. It might be in other states.
Okay. Next question. Have you seen the use of peer recovery coaches with SUD moms?
I have not with coaches, but definitely like peer support groups are very helpful. And actually Postpartum Support International has several support groups for any demographic you could think of. So that's definitely a good resource because peer support groups definitely make a huge impact on recovery in general.
Okay, going back to the Medicaid question, they have a clarification. She meant, as far as resources for Medicaid patients, she meant like counseling resources.
Okay.
She
Counseling.
said she said her patients state that they call all the counselors that accept Medicaid and are told they are no longer taking more patients.
Yeah. I know that's rough. So I usually start off with like the state funded programs. So like any state funded local clinics, they are normally the ones that take Medicaid. A lot of people have sliding fee scales. I know that still might not even people still may not be able to afford therapy even on a sliding fee scale. So that's one of those things that I'm definitely trying to figure out a way to be able to serve that population of people. But also, just not being able to hurt the provider, and they have to run a business, but to still be able to help that population that has Medicaid or cannot afford to pay out of pocket. I would still say SAMHSA. I would say check in with like LDH or whatever your local government office is. They should have resources on their website that take Medicaid. And in the meantime, like when people cannot get in to see anybody, I tell them to just make sure that they're keeping up regular visits with like their PCP, maybe having more frequent visits with their PCP, because some PCPs are able to or they feel more comfortable prescribing medications. And that way they could keep tabs on that individual. Can also give referrals as well. And then also I suggested them trying a peer support group in the meantime, just so they at least have some form of support, even if they can't get in to see a therapist right away.
Okay, next question. How long does THC stay in the system of babies after they are born? And then another question to follow up with that. Sorry. How long would you see symptoms, and is cognition affected long term?
Yeah, I do not know the answer to that question, but that's a good question though.
All right. We're going to move on to the next one. Let's see. Anecdotally, I have seen NAS worse with methadone treated moms than those on the actually illicit substances. Is there any research that discusses the different withdrawal symptoms when it comes to like severity in neonates?
I haven't seen that when I was doing my research for this, but that is interesting that she's seen more of it with the methadone. But that may be a reason as to why a lot of methadone clinics at one point, they were not taking pregnant women. I just know in Louisiana, maybe in the last 2 or 3 years, probably since the pandemic, was when they started taking pregnant women.
Okay. And last question, as a postpartum nurse, what can I be doing to better support my patients who have dealt or are dealing with substance abuse, especially while they are in the hospital?
I would definitely just sit down and have a conversation with them and ask them what they need, because that's going to be based on the individual, and just coming to them with just like a non-judgmental presence, and just letting them know like it's kind of hard to take our therapist hat or our nurse hat or our doctor hat off. But sometimes they just need to be talking to, like this person, you might be a parent. So just kind of tune in with, just being non-judgmental and just coming from a place of wanting to truly understand and see what they say their needs are. And then, of course, those resources that I gave earlier, postpartum.net, SAMHSA.gov would be great, just to have those readily available to somebody who says, like, I want to get treatment now. That way you already have it and they don't have to wait on anything, and they can have it before they leave. So I would definitely say just have a list of things that you can give them, or maybe even have the social worker at the hospital to go ahead and set some of those appointments up already so they leave the hospital with that reassurance.
Okay, we've got 2 more questions. What kind of resources are available for parents or guardians who are caring for children severely affected by substance abuse during pregnancy, like physical or mental disability?
Gotcha. So I believe postpartumsupport.net has a group for parents and caregivers of children with special needs, which some of those children may have special needs. I would say just maybe looking up in your area, if there are any caregiver groups. Sometimes those children are seen by places like Early Step, and other programs like that that kind of evaluate children at a young age. And so they usually have some sort of support groups for parents and caregivers and guardians. So that would be my recommendation.
Okay. Someone.
Sorry, that was me. I didn't realize I was.
Okay. Sorry about that, everyone. Okay, last question. Are there universal naloxone distribution programs for people discharging from birth at hospitals or birth centers?
No.
Okay.
Not to my knowledge, anyway.
All right. Well, thank you.
Yes, thank you very much, Ms. Lattin. That was a wonderful presentation. And it definitely identifies a lot of areas where we need to see a lot of work done.